Hello, I'm calling for a refill.
Everyone, welcome to the Refill Podcast, one of the only podcasts where we fill you in on the news and happenings in the pharmaceuticals world. My name is Burlington Mercier, aka Bernie, and I'm here with.
Hello, everyone. My name is Obinna Njeze. How you guys doing? Hope you guys are all doing well. Bernie, how you doing?
I'm doing great. Let's hop straight to it. On this podcast, we're going to talk about community pharmacy and all the issues that's been happening currently, especially regarding decreasing reimbursement rates, PBMs, and essentially how to solve it, potentially solve it. So stay tuned. Alright, before we dive in, OB, if you don't mind, can you please describe what the role of a community pharmacist is?
The role of community pharmacy, I like to describe it as the last line of defense in the healthcare system. So I would describe like the first line as the doctors and nurses when you go into hospitals or clinics, where you go, you get your diagnosis, doctors will write up a prescription, and then now they will send it to the pharmacy, which is where the patient will now go and pick up the prescription. So now, as the last line, after us, the patient will now be on their medication to try and get better. So it is the pharmacist's job to make sure there's no errors and that everything, from the doctors down to us, the prescription, the drug that they're getting, the dose that they're getting is correct. So that's why I like to describe us pharmacists as the last line of defense.
Yeah, I totally agree. Not only are we the last line of defense, we're actually one of the most accessible healthcare professionals out there. Like, think about it. When's the last time you've been to your doctor's office? Like, more than like a year or so. Patients who have no conditions, they probably go to their doctor's office maybe in a year, like every few months. And even for them, they're in the pharmacy more often than that. So we are one of the most accessible healthcare professionals out there. And the benefit of that is that we are heavily involved in keeping patients healthy and making a true difference in their lives. Like, I think back when I was working in the pharmacy at Big Box Store, at Walgreens. Patients all the time came to the counter expressing their gratitude and how appreciative they were for the level of service we gave, the level of care we gave to them, and truly making their difference at improving their quality of life. Making sure their medications are safe, making sure their medications were on time for them to manage all their conditions. So I totally agree with you on that we're the last line of defense, especially. But with that benefit, like the counseling, such like that, comes with a lot of cons, as a real address. Sorry. Yeah, I totally agree with you. Just going back to what you said about the slow decline that you see over time. Just to quote an article here, the pharmacy reimbursement crisis. This was published in 2020 by the National Association of Chain Drugstores. Essentially, outlined how retail pharmacies are in a crisis, facing unsustainable financial pressures as they are increasingly reimbursed by payers below the cost of buying and dispensing prescriptions. So just like we talked about, like the reimbursement fees, they are essentially getting, the reimbursement are basically getting decreased over time, and retroactive fees such as direct and indirect remuneration that occur like weeks or months after a transaction closes. Basically, the insurance companies decide to recoup a portion of the pharmacy's reimbursement, meaning that the pharmacy can't really sustain themselves anymore. So just to some figures, in December 2017, the article outlined that there are approximately about 59,000 pharmacies, and by the time it reached December 2019, this is pre-COVID, mind you, the number of pharmacies that were available, the retail pharmacies that were available, was just a bit under 57,000. It's approximately 2,000 fewer pharmacies, So, this is just chain drugstores overall. Recently, there's an article that will outline later on by Walgreens that show that the pressures they faced as well.
Big box stores like Walgreens were not safe from decreased reimbursement rates or issues with PBMs, as well as an article published last year by the Wall Street Journal in June 2027 outlined that Walgreens planned major U.S. store closures, and that the pharmacy chain plans to close a significant share of its nearly roughly 8,600 stores. So, in this article, Walgreens CEO Tim Wentworth was interviewed about why Walgreens was performing so badly, and in this article, Mr. Wentworth outlined that Walgreens were facing increased pressures from firms such as PBMs, which Obi will explain further, that negotiate drug prices on behalf of insurers and employers. And due to decreased reimbursement rates, stores were not able to be profitable and be open. So due to this, Walgreens had to close many unprofitable stores in response to the rest of concerns that they overexpanded. And due to this, Walgreens decided to close bunch of its stores. And like I said further, the CEO basically said in this article as well that Walgreens was losing a bunch of money on prescription drugs such as Ozempic and Mounjaro. And just this year, if you read the news in March, in March, Walgreens went private. They were bought out by the private equity firm Sycamore Partners in a $23.7 billion deal. This followed after last year that Walgreens lost billions of dollars and had to close more than 10% of its locations. So this caused many of a domino effect, and Obi will explain how this even started and how pharmacy benefit managers contributed to it.
Pharmacy benefit managers they're like the middlemen with medication pricing. So, the wholesalers will have the price for medication, but then patients only get a certain amount. So, to calculate all that money that, will be paid to pharmacy benefit managers, that's where the pharmacy benefit managers come in. So they're middlemen with medication pricing between the pharmacy and patient to negotiate what the price will now come up to. And through rebates, which is a partial refund to someone who has paid money. That is how these PBMs get their money. That's where they make their living off of. These PBMs are insurance companies like United Healthcare, Blue Cross, and then they dive down into Optum, Express Scripts, Caremark, Aetna, and various other private insurance or Medicare, Medicaid insurances.
Yes, to add further context, in an article published in the Future Healthcare Journal titled Stars, Stripes, and Scripts, Innovations and Challenges in U.S. Pharmacy, the article outlined how big of a problem PBMs are. It stated that the biggest blame, from the state of Washington, that 83 pharmacies closed in the past 18 months period. This article, Stars, Stripes, was published in December 2024. So the 83 pharmacies closed in the last 18-month period, and that the biggest blame was placed on pharmacy benefit managers, on the CEO of Washington State Pharmacy Association, Jenny Arnold, said that if a pharmacy decides not to take PBM contract, they can lose a third of their business overnight. But it's stuck between a rock and a hard place because they lose money on the contract or they lose a third of their patients. It's really a lose-lose for pharmacies. The Journal of Missouri State Medical Association further adds, PBMs use their market leverage to increase their profits, not reduce costs for consumers. Incredibly, PBMs own their own pharmacies. This ownership further creates huge conflicts of interest, hurts conversations, and distorts pricing. And this just table that shows that fees from PBMs increased more than 300% over the last decade from 2012 to 2023. Now, the domino effect that decreased reimbursement and issues PBMs have is that now there's less fulfillment as community pharmacists who can accomplish many crucial tasks now feel unmotivated to complete those tasks as they are not properly reimbursed. Causes higher patient copays. As to stay afloat, some pharmacies may outright decline insurances, and which leads to patients having to pay more out of pocket. This can also cause decreased crucial medication supply, as some pharmacies who decide that if they're losing money on a certain medication, let's say an inhaler, and the patient who has asthma really needs it, however, the pharmacy can't afford to have those inhalers, they lose out on that. And additionally, due to the decrease in reimbursement on medications, it causes increased financial stress upon pharmacies, which leads to more staff cuts down from pharmacists to technicians to other employees in the pharmacy. These are all big issues, and there's a few ways that we as pharmacists can go about solving it.
They're trying to make ways to allow pharmacists to work around this reimbursement issue, and see these PBMs have given us a way, even though they're taking our money, they've given us a way to make money to, I guess, compensate. It's called medication therapy management. But this program is for us pharmacists to find a way to make more money. It's like a win-win-win kind of situation. Pharmacists make money, and they inform and educate patients on the medication that they're taking, to make sure that they're taking the medication when they need to be taking it, make sure they are known when they're getting the refills, some adverse effects that they may experience, and like how to prevent that from happening, and any other information that the pharmacist, any other question the pharmacist that might have that us pharmacists can answer. So, and then for the PBMs, it allows them to spend less money on patients, because if a patient is staying healthy, the insurance company does not have to spend as much money on them to keep them healthy. So this program is kind of like an incentive for us pharmacists to reach out to make sure that these patients are staying healthy, because at the end of the day, nobody wants people to get more sick. So I guess this is PBM's way of expressing that, I guess, that kindness.
Yeah, I totally agree with everything you said. And additionally, pharmacists themselves must continue to advocate for reform, as published in the Stars, Stripes, and Profits article. It stated that in New York State, in New York and other states, there's actually legislation that restricts PBMs to participate in state Medicaid programs. So this is really crucial, as it shows that pharmacists have the ability to advocate for themselves if they want to continue to pursue the reimbursement models. And also, other solutions out there is to switch from reimbursement models to more value care models, like what we were saying, carrying out MTMs and conducting CMRs, performing point of care testing, and be compensated for that, as outlined in the pharmacy reimbursement prices. We outlined getting reimbursed for health tests, screenings, management of chronic conditions and medications, immunizations, and point of care testing. Those are all crucial things that pharmacists can be the head of and lead. And also, as we learned from the speaker from CPDSN, is leveraging technology to our best of our advantage. So carrying out delivery services with text reminders, potentially carrying out virtual CMRs, and things of that nature. And these are all things that can mitigate and help declining pharmacy reimbursement and issues with PBMs. And then just to conclude, reimbursement really has changed in pharmacy. And however, we as community pharmacists must adapt so we may continue to be open to serve the public and to ease the ever-growing burden placed on community pharmacists today. Thank you all for listening, and Obi has some few words.
Yeah, no, I appreciate you guys for listening. Bernie, I appreciate being able to sit down and talk about this issue, talk about this topic. I believe there's even things that I even learned speaking to you about this. And I hope that the viewers, I hope that you guys all took something out of this and learned a thing or two. And hopefully we will push for a brighter future for our profession.